Hernández, a pediatrician, Mexican Navy. I appreciate the opportunity to present today a clinical case that represents the experience obtained by the multidisciplinary team of the Naval Medical Center for the diagnostic and therapeutic approach of a rare disease in our pediatric population, such as a giant choledochal cyst. We will begin with the presentation of our patient, a 12-year-old female adolescent, originally from and resident of the city of Acapulco, Guerrero State in Mexico. As an important antecedent, the mother of the patient reports adequate hygienic dietary habits with a regular pattern of evacuations every 24 to 48 hours, with stools type 3 to 4 on the Bristol scale, a complete vaccination schedule according to the booklet national. She also refers to a previous surgery for appendicitis at 2 years of age and a hepatitis A virus infection without apparent complications at 10 years of age. No other prenatal, perinatal, or postnatal history relevant to the current condition. From the 6 months prior to her admission to the pediatric service at the Naval Medical Center, she was reported with multiple visits to the emergency service at the head Acapulco Naval Hospital due to predominantly abdominal pain in the epigastrium as the only symptom. 6 months before her hospitalization, the patient was with outpatient management with pharmacological treatment. Initially, due to the suspicion of acute gastritis, they prescribed omeprazole 20 milligrams orally every 24 hours for 7 days, with little clinical response, extending the management to 30 days, with a subsequent decrease in symptoms. 1 month later, she presents a new symptom of generalized abdominal pain, diagnosing her with irritable bowel syndrome, for which she started an antispasmodic with 5 milligrams of oral butylicin every 8 hours for 7 days, improving temporarily for 6 weeks. For the 3rd time, she presented a picture of generalized abdominal pain, predominantly in the epigastrium. So, antispasmodic treatment was started, prokinetic with 40 milligrams of oral dimeticon every 8 hours for 14 days, and 375 milligrams of oral metamizole in case of severe pain was added. These medications were suspended by the mother when she perceived clinical improvement, restarting them intermittently without a medical prescription. Until then, no laboratory or office studies were considered necessary. The last 5-day history of predominantly epigastrium abdominal pain began without radiation, burning, transflicted with progressive increase accompanied by jaundice, coluria, and intestinal constipation. She received pharmacological management with 40 milligrams of intravenous omeprazole every 24 hours and 40 milligrams of oral dimeticon every 8 hours, presenting partial improvement during 72 hours. Subsequently, she began with nausea and vomiting on 6 occasions of gastroalimentary content, progressing to gastrobiliary, for which an evaluation was requested from the pediatric surgery service. Due to the insidious clinical evolution, up to that moment, an evaluation was requested by the pediatric surgery service. On physical examination, the abdomen was tendered to palpation deep in the epigastrium and under the right costal margin, without detecting masses or visceromegaly. Laboratory studies were requested, finding alterations in liver function test, with hyperbilirubinemia and the expense of direct bilirubin, elevate gamma-glutamine transferase, and elevate transaminases, suggestive of a cholestatic pattern, pancreatic enzymes with normal parameters for the age of the patient. Initially, as a complementary diagnostic approach at the Acapulco Naval Hospital, a simple and contrast computed tomography of the abdomen was performed, reporting a probable pancreatic cyst. Therefore, she was sent to a tertiary care hospital for multidisciplinary management. Upon admission to the Naval Medical Center, an ultrasound of the liver and bile ducts was performed, as well as cholangioresonance, with a report of aneurysmal dilatation of the bile duct, compatible with a 6.9 by 3 by 2.7 centimeters choledochal cyst. After carrying out the complementary laboratory and office studies, the medical diagnosis of choledochal cyst and cholangitis are integrated. Therefore, pharmacological treatment with antibiotics was started, based on 1 gram of intravenous cefotaxime every 8 hours, and analgesia with 350 milligrams of intravenous paracetamol every 6 hours to improve her clinical conditions. And definite surgical treatment was performed after 72 hours by means of an exploratory laparotomy with a 1-to-1 hepatic duodenal anastomosis. Complete resection of the cyst was performed. Figure number 1 is an intraoperative photograph with a 10 by 15 centimeters giant bile duct cyst that does not show adherence around it, but with data of a chronic inflammatory process. In figure 2, we can see the dissected cyst. In figure 3, we can observe by means of an intraoperative cholangiography the postoperative evaluation of the bioenteric anastomosis and images of the intrahepatic and extrahepatic duct with stenosis of the right hepatic duct, suggestive of Todanis type 1 giant choledochal cyst. During the intermediate postoperative period, 50 milligrams of ketorolac intravenously over 24 hours was added to the previous treatment to improve analgesia. The patient evolved favorably, presenting a decrease in jaundice 48 hours after surgery, with a report of 1.8 milligrams over deciliter of total bilirubins. She started the oral feeding on the 5th postoperative day, and on the 7th day of hospital stay, the antibiotic was suspended. She discharged from hospital on the 9th day without eventualities. In the follow-up by the pediatric surgery outpatient clinic, she has remained without complications and with normalization of liver function tests, with a good prognosis for the life and functions. To conclude this case report, based on the experience of the Naval Medical Center in Mexico, I consider it important to remember that the clinical suspicion of a choledochal cyst should be followed by an early diagnosis and treatment in view of the possible life-threatening complications and the high risk of malignancy. So, now we will carry out a brief review of the current literature in relation to this disease. We will start by remembering that it's common to use the term choledochal cyst, but semantically it is more appropriate to say bile duct cyst, because cystic dilatation can occur in any part of the bile duct system, not only in the choledochal duct. Cysts on the bile ducts are usually a childhood surgical problem. However, in almost 20% of patients, the diagnosis is delayed until adulthood. The choledochal cysts are congenital dilatations of the biliary tree in the intra-extrahepatic or extrahepatic bile duct. Their size varies from 2 to 9 centimeters in diameter. Greater than 10 centimeters, they are considered giants. Consider benign disorders. The light in diagnosis lead to severe late complications, cholangitis, pancreatitis, cholelititis, and malignant transformations. Remembering a bit of history, it is important to mention that the first description of a fusiform dilatation of the choledochal duct was published by Butter in 1723. First authentic case was reported by Douglas in 1852. Pancreatic biliary junction fail was first noted by Kusumi and Kodama in an autopsy case with congenital biliary dilatation in 1916. This initial observation did not attract attention for many years, but the concept has been accepted widely since Barrett reported the anomaly in 1969. Incidence. Choledochal cysts constitutes 1% of benign biliary pathologies. They are found at any age. but more than 2/3 of the cases are diagnosed in children under 10 years of age. Only 20% of the cases correspond to late diagnosis, as in the case of a patient diagnosed at 12 years of age, and some cases are diagnosed prenatally. Its prevalence is up to 3 or 4 in women for a case in men. Western countries, 1 in 1,100 to 150,000 in live births. Japanese population, 1 in 1,000. In Mexico, we do not have incidence reports, but the National Institute of Pediatrics reports in a series of cases that is diagnostic between 0.5 to 1 case per year. The exact etiology is unknown. Abnormalities during the early development of the hepatic diverticulum are believed to be responsible for the abnormal junction on the pancreatic biliary conductors in 50 to 80% of cases. This causes the union of the pancreatic and bile conductors outside the duodenal wall and proximal to the ampulla of Batten, which favors the reflux of pancreatic juice towards the bile duct, causing a mechanical strain of the bile duct, inflammatory change, mucosal and muscle wall degradation. Another causes of choledochal cyst is related to weak bile duct wall, distal biliary obstruction due to protein plugs of pancreatic juice and gallstones, a sphincter of other dysfunction, and embryological and motility disorders due to the fact that fewer ganglion cells have been observed in some patients equivalent of Hirschsprung disease of the colon. The current classification is a modification of that of Alonso led by Todani, based on the location of the cyst in the bile duct. 5 types of choledochal cysts are specified. Type 1, 80%, consists of cystic dilatation of the choledochal duct with a normal intrahepatic bile duct. The dilatation can be spherical, 1A, segmental, 1B, profusiform, 1C. Type 2, 4%, diverticulum of the common hepatic duct or choledochal duct. Type 3, or choledococele, 1 to 2%, dilatation of the intrapancreatic choledochal duct in the wall of the duodenum. Type 4, 50%, is intrahepatic and or extrahepatic cystic dilatation of the bile ducts. It is divided into type 1, 5A. Multiple intrahepatic and extrahepatic cysts are type 4B. Only multiple extrahepatic cysts, type 5, or Caroli's disease, is the cystic dilatation of the intrahepatic bile ducts with the normal extrahepatic route. Within the clinical characteristics, the classical presentation includes the triad of abdominal pain, jaundice and palpable mass in the right upper quadrant, being more common in children than in adults. However, the clinical presentation varies by age group, cyst size, and degrees of biliary obstruction with or without concomitant cholangitis. Most patients have 1 or 2 elements of the triad. It most often consists of non-specific abdominal pain as the initial symptom in children older than 1 year of age and abdominal mass in infants. Signs and symptoms related to associated complications such as obstructive jaundice, cholangitis, pancreatitis, portal hypertension, liver functions abnormalities, and coagulopathy may also occur. Among the different studies that have been carried out, we can cite Babedine et al., who reviewed the medical records of all patients diagnosed with choledochal cysts between 2005 and 2015. Demographic data, initial clinical presentation, positive findings on physical examination, history of any notable behavior, imaging modalities, and some laboratory values that we will discuss later. The patients were divided into 2 groups, under 1 year, infants, and 1 year to 18 years, older children. Demographic data, clinical data, and laboratory values were compared between infants and older children. The study included 32 patients with a diagnosis of choledochal cyst. 9 patients were infants and 23 patients were older children. Abdominal pain was the most common presenting symptom, followed by nausea and vomiting and jaundice. None of the patients presented tears. Abdominal pain was found in 20 older children. However, none of the infants had abdominal pain at the time of diagnosis. On the contrary, abdominal mass was detected more in infants than older children. In our case, the patient presents abdominal pain, and 6 months later, jaundice was added. Investigations in relation to the complementary study for the diagnosis. Patients sometimes temporarily show abnormal values of bilirubin, amylase, and transaminases. They are only evident during the symptomatic phase. In addition, age should be considered when evaluating pancreatic amylase levels because its levels are low in newborns and infants. Serum laboratory tests used for diagnosis include liver function tests in the presence of a cholestatic pattern, accompanied by disproportionate elevation of alkaline phosphatase, gamma-glutamyl transpeptidase, and total bilirubin relative to aminotransferase. Other abnormalities in laboratory tests are secondary to complications. For example, elevate pancreatic enzymes in patients with pancreatitis and leukocytosis in the presence of cholangitis. Ultrasound is the imaging study of choice for the initial confirmatory and postoperative follow-up approach, currently allowing prenatal diagnosis as a finding of a simple cystic image at the level of the upper right hemi-abdomen in the second or third semester of pregnancy. Regarding the study methods, abdominal ultrasound is useful in 92% of cases for the diagnosis of cystic malformations of the bile duct, describing a diagnosis sensitivity of between 71% and 97%. Specifying with precision its size and its location. However, there may be a failure in the diagnostic in up to 30% of cases. In the initial report case, a simple and contrast abdominal tomography was requested. However, the abdominal ultrasound was the imaging study that provided us with the best evidence regarding the characteristics of the choledochal cyst, also offering advantage as it is a non-invasive method and low cost. Continuing with the complementary imaging studies for the diagnosis, it is suggested to perform a preoperative simple and contrasted computed tomography of the abdomen to show the continuity of the cyst with the biliary tree, its relationship with the adjacent structures and the presence of associated malignancy, as well as magnetic resonance, cholangiopancreatography to visualize the anatomy of the malformation of the bile duct and the pancreas, cobillarity junction, and identify vascular compromise. For example, of the clinical case described, in figure 1, we can see an axial section in a computed tomography of the abdomen that shows the saccular dilatation of the interhepatic bile ducts. The saccles are large and distributed with the left lobe. It is important to mention that endoscopy retrograde cholangiopancreatography was a technique of choice for the preoperative study, but nowadays it is recommended to replace it with cholangioresonance, since it is a non-invasive examination with fewer complications. There are no clear evidence-based recommendations on the timing of surgery. However, because poor pancreatic biliary junction increases the chances of developing biliary carcinoma and the risk that cancer might develop in young patients, surgery is recommended immediately after a definitive diagnostic is made. Symptomatic neonates and infants should be operated on as soon as possible, and only elective surgeries will be performed in asymptomatic cases between 3 to 6 months of age. The definite treatment is surgical resection. The most commonly used surgical technique is to remove the entire extrahepatic bile duct and perform a reconstruction of the continuity of the bile duct using raw, white, and hepatic jejunum to separate the bile and pancreatic ducts to prevent the free reflux of pancreatic juice into the bile duct. The surgical technique depending on the time of choledochal cyst. In this case, report a type 1 cyst was presented. So, within the options for its resolution, it is recommended hepatic raw NYG or laparoscopic resolution with a hepatic duodenal anastomosis, as in the case of a patient which can be safely used for reconstruction of the bile duct in this pathology, because it's improved the clearance of the bile content of the duodenum, preventing residual accumulation towards the interhepatic bile duct, reducing the risk of cholangitis and offering technical advantage over other procedures described, with respect to shorter surgical time and tissue manipulation, reducing the possibility of intestinal adhesions. The surgical treatment of choledochal cyst has a good prognosis, with more than 90% successful resolution and low postoperative morbidity and mortality, with a survival greater than 90% at 5 years. However, the risk of biliary malignancy, mainly cholangiocarcinoma, increased 20 to 30% for type 1 and 4 cysts, even 50 years after the excision. Postoperative complications occur more frequently in adults. Type 4A cysts are associated with postoperative complications, such as gallstones and liver stones, cholangitis, biliary cirrhosis, and anastomosis stenosis, including a hydatid cyst inside the biliary cyst as an atypical compilation. Follow-up should be carried out with biochemical evaluation and abdominal ultrasound, strictly in patients with persistent interhepatic biliary dilatation. In our clinical case, the patient remains uncomplicated so far, since complete resection was achieved. Conclusion. After having commented on our experience in solving a clinical case and reviewing the literature in this regard, we can conclude that choledochal cyst represents a diagnostic challenge, so we must resort to meticulous observation of the clinical signs, which could guide us to the importance of early clinical determination of bile duct cysts of congenital etiology, with late diagnosis lies in its association with future complications, mainly cholangiocarcinoma. It is for this reason that it is extremely important to support ourselves in the technological advance of radiological studies, which allow accurate diagnosis and in turn facilitating the establishment of the best technique for definitive surgical correction and reducing the risk of complications. I hope that this brief review of the literature on the subject and the presentation of this clinical case have been useful to continue our daily professional practice. For your attention, thanks.